Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. This episode features content regarding a call to action for universal screening for hepatitis delta. During this podcast, Dr. Maria Buti, Professor of Medicine at the Hospital Universitario Vall in Barcelona, Spain, and Dr. Robert Gish, Professor of Medicine at Loma University in Loma, California, and Medical Director at the Hepatitis B Foundation in Washington, D.C., discuss who to screen for hepatitis delta and how to screen those patients. For more information about Dr. Buti and Dr. Gish, and for a link to the full online educational program, please visit the link in the show notes for this episode. Now, let's get started and hear what Dr. Buti and Dr. Gish have to say about their call to action for universal screening for hepatitis delta.
My name is Robert Gish. I'm from the United States. I live in San Diego. I'm the medical director for the Hepatitis B Foundation, but I practice in California and Nevada, have 6 clinic sites where I see patients weekly or monthly, and very involved with hepatitis B and delta assessment. Maria, I'll go back to you for introductions.
I am Maria Buti. I am Professor of Medicine at University Autónoma of Barcelona, and I have my clinics at Hospital Universitario Vall in Barcelona. I have worked in hepatitis delta for a long time. I did my doctoral thesis in hepatitis D 2 years later than Mario Risetto discovered hepatitis delta. And one of my first papers was the prevalence of hepatitis delta in Spain. So I am very happy today to talk on hepatitis delta. Hepatitis delta is the most severe form of viral hepatitis, with higher rates of hepatic decompensation, hepatocellular carcinoma, and liver transplantation in people with chronic hepatitis D, compared with those monoinfected with hepatitis B and those monoinfected with hepatitis C. Recent estimations suggest that the prevalence of hepatitis delta in people positive for HBs antigen, which indicates current hepatitis B infection, range from 4% to 14%. That represents approximately 12 million, between 12 million to 43 million people worldwide infected by hepatitis delta. However, the prevalence of hepatitis delta remains a challenge. And this is in part due to the geographical distribution of hepatitis D. Also, the different prevalence in different clinical settings, lower in blood banks, intermediate in people with risk factors, and high in patients with liver disease. In addition, the limited access to hepatitis D tests, particularly in low-income countries, accompanied with these variable and inconsistent screening recommendations of the international guidelines, make even more difficult to diagnose hepatitis D, and this help to have a large number of undiagnosed cases. If you look at European guidelines, the guidelines of European Association for the Study of the Liver, the recommendation is to test all HBs antigen people. That means at least one time a single test for hepatitis D among all HBs carriers. And this is similar to the APASL guidelines, to the ASEAN Pacific guidelines. But the recommendation in the ASEAN Pacific guidelines, it's a bit lower, because this recommendation is only for patients with liver disease, not for all HBs antigen positive. What are the recommendations in your country, in US? What AASLD guidelines are currently recommended?
Fantastic. And it's interesting that when you say AASLD, it's American. And when we think of America, we think of at least Canada and Mexico, if not more. So ASLD also tries to have a global impact, although I would have to state that EASL is quite global and APOSL specifically for the Asia Pacific region. But the guidelines here take HBsAg positive patients, and then you have to do a risk factor analysis. And usually that is matched with low or undetectable HBV DNA and high ALT. So this is pretty complicated. And this is 2018, so it's nearly 4 years old. And hopefully it's going to change. We'll talk about that. WHO, the real global organization, has no recommendation. And then finally, the Hepatitis B Foundation, where I'm the medical director, which also tries to have a global impact, made it very simple: all patients infected with hepatitis B. So it sure would be nice, Maria, if we could harmonize all of these. Maria, we just went over who to test, but we didn't mention how to test. What's your algorithm for testing? And I have a couple specific questions about this strange test called delta antigen or delta IgM.
We usually test hepatitis D by anti-delta antibodies. I think everybody agrees that this is the first test to detect hepatitis delta. And in those patients with anti-delta positive antibodies, the next step is to test for viremia, for HDV RNA, because it's very well known a relatively small percentage of patients don't have active delta infection. They have antibodies, but without viremia. It's about 24% of the patients with hepatitis delta antibodies. Some of them have cleared spontaneously hepatitis D and another with the current treatment. So I think it's important first, as a screening test, use anti-delta antibodies, and in those positive cases, go for HDV RNA. But in a similar way that we are now doing with hepatitis C, that we test for antibodies for hepatitis C, and then we are promoting reflex testing for hepatitis C for viremia. I think in the future we have to do something like this for hepatitis delta, probably with anti-delta antibodies. So I think a good way to diagnose these undiagnosed cases is the implementation of reflex testing for anti-delta antibodies in all HBs antigen positive cases, following EASL guidelines. I can tell that here in Spain, we have recently presented at AASLD meeting in last November an oral communication looking at the adherence of EASL guidelines of recommendation for testing hepatitis D in HBs antigen positive people. And we found that the adherence of this recommendation is low, particularly in primary care settings. It's much higher in liver units. But in primary care, the majority of even having access to the test, a high number of them, of physicians, are not testing for hepatitis delta. What is your experience?
Very interesting, very similar. And we have settings in the US where the testing may be as low as 5%, and then some specialty clinics where it's been 100%. But we typically quote 20% compliance. That's from a paper that Nancy Rowe had from Chicago. And there has been a lot of confusion about what tests to do, because you can order Delta antigen in the United States, but nobody knows how to use the test. So I'm recommending don't order it. And same thing with Delta IgM antibody. It's very confusing how to use IgM. And I just also recommend providers not to use the IgM until we have better refinement of the test utility. So I agree, antibody to RNA, there should be reflex testing. But we have a problem, Maria, in the US, because one of our major labs, LabCorp, which probably has a 20 to 30% market share of all laboratory testing in the US, doesn't offer antibody or PCR testing. So if you have to go to LabCorp, you have to order through LabCorp under contract. you won't get the test done because they're not going to send it to Quest, the other major competitor. Quest has been at the forefront of testing for lots of different types of liver disease. They came out with a quantitative surface antigen a number of years ago when some of our key diagnostic companies wouldn't bring that to the FDA. It's an LDT, of course, and these Delta tests are LDT, but the criteria in the US for laboratory determined tests are very high standards, and they're equivalent to, in my opinion, FDA criteria or standards for clearance. So you can trust the test if it comes back positive or negative, which is important, but there has to be access. The VA, a giant healthcare system, veterans in the US, has specific labs they send to, so you can get it done through the VA. Kaiser, another giant healthcare system in the US, also you can send to reference labs. But LabCorp is a big gap. I've been on the phone with many labs, including ARUP, Mayo Clinic, LabCorp, Quest, and others, trying to bring about easy access to testing. And what you said, reflex testing, Maria, extremely important.
I think in Europe, we have in some countries some difficulties or limited access, particularly in some Eastern European countries. But in the majority of Western European countries, anti-Delta and HDV RNA, it's easy to have. So people use anti-Delta antibodies without any problem. Anti-Delta IgM, usually in case of anti-Delta, total anti-Delta positive, and Delta antigen, it's very infrequent. So I think the key message are the use of anti-Delta antibodies for screening and HDV RNA for viremia. Another important point is to look to these anti-Delta positive people and look at the characteristics. And if you look at those people with anti-Delta antibodies, the majority of them, at least here in Spain, are people who were born outside of Spain. That means mainly from Romania, Mongolia, Sub-Saharan Africa. So this means that some of these persons have difficulties to access to the healthcare system. So for this reason, it's also important to look hepatitis Delta in these communities of hotspot countries with a high prevalence of hepatitis Delta. And I am sure that in your country, you also have a very highest prevalence in people from Mongolia or Eastern European countries, and here in Europe, particularly for Sub-Saharan Africa.
Really good points. The geographic and ethnic distribution in the US is highly variable. I had a paper in 2012 looking at Northern California, and 25% of our patients were Caucasian, mostly males, mostly with risk behavior, either sexual exposure, IV drug use. So, but you're right, we have a very large Mongolian population that's in the Chicago area, the Northeast corridor, some in LA and San Francisco also. We have Eastern European and what I'm going to call Mediterranean and Eastern Mediterranean. There's a Turkish population here, Armenian population, some patients from Central Asia. We have Chaldeans from Iraq. There's 40,000 Chaldeans that live in San Diego. These are Iraqi Christians. So because of the Delta in the Middle East, we have to always be thinking and testing. There's Delta in Egypt. We have a number of Egyptian patients in the US. And that's why we just need to test everybody. This issue about risk, it gets really complicated. And its risk history is stigmatizing. What do you think?
I think it's very important having guidelines similar to the European ones that clearly are in favor to testing for everybody, because as you know, patients with liver disease have some degree of stigma, and recognizing this geographical distribution of hepatitis Delta, if we like to increase the number of patients diagnosed with hepatitis Delta, clearly we have to go to a general screening for all HBs antigen positive. And I think this can help to educate of primary care physicians and other healthcare providers to implement HBs antigen testing. This will be easier and better than to test only high-risk groups. But we have also good news, and the good news are that hepatitis B immunization also protects for hepatitis delta. We don't have a specific vaccine for hepatitis delta, so we cannot prevent superinfection of those HBs antigen carriers, but we can prevent hepatitis B and hepatitis delta with hepatitis B vaccine. Bob, do you like to talk a bit more on this?
And it's fantastic lead in because 2 weeks ago, the American College for Immunization Practices, I think it's American Committee for Immunization Practices, came out with the statement to vaccinate all adults up to age 59. There's a whole discussion about that age barrier. And then we expect the CDC to come out with the statement to test all adults for hepatitis B before February. So when they harmonize test all, vaccinate all, next step was to work with our advocacy groups, our policy groups, hopefully AASLD, to come out and say surface antigen positive means delta antibody reflects the PCR. So we're hoping in 2022, we're going to have this 4-step process, including vaccination. But we have 160 million people in the US who are not immune or exposed to hepatitis B. So I think a mass testing and vaccination program like coronavirus is in order. And then we have a statement at the Hepatitis B Foundation. It's called Know Your ABCs. You should know your hepatitis A immunity status, your B triple panel, your C antibody, and of course, your corona status.
Yeah, that's a very good news. So I like this new recommendation, but I was also a bit surprised. I was a bit surprised because the high risk of chronicity is in newborns and in children. So I hope you also have a recommendation for immunization of all newborns, because when hepatitis B is acquired during the perinatal phase, the risk of chronicity is very high. So I hope you have both recommendations.
Yes, the pediatric, the newborn vaccination policy, I think started in 1994. And we have some cities like San Francisco that are in excess of 97% compliance. There are some more rural areas of the country where it's lower than that, but we have a very, very high compliance rate with that newborn vaccination. And of course, screening all mothers for hepatitis B was started a number of years ago. And then managing the mothers correctly, depending on their viral load, has also been part of it, using a tenofovir-like drug for the last trimester. The viral load's over 200,000. So test and link to care is part of pregnancy, a little bit more complicated. We're trying to make it simple for all other adults. What's your comment on this 59-year-old? It's almost as if when you're over 59, you're not an adult anymore. What do you think?
I think, as I mentioned before, that it's a good recommendation, but it has to be with vaccination of the newborns. In Europe, there are very active programs for vaccination of newborns, and this is one of the goals of the WHO viral elimination program by 2030. So I think for hepatitis delta, we need to test and also to prevent, using hepatitis B vaccine.
Excellent. We did have a little bit of a big discussion, big discussion about this 59-year-old age boundary for vaccination, because there is hepatitis B, acute hepatitis B when you're over 60. There's both medical device transmission of hepatitis B and sexual transmission of hepatitis B. It's not like when you're 60, you don't have sex anymore. When you're over 60, you're not getting medical care anymore. There are outbreaks in retirement facilities, medical facilities, nursing homes that have been reported extensively to the CDC. So we're going to try to get them, just to make it simple, test all, vaccinate all, not have age issues built into that. But that's another battle for 2022.
So my recommendation is to test all HBs antigen positive for Delta. This is the only way to identify patients with hepatitis Delta to linkage to care and to cure. And I am sure that in the future, we are going to have better therapies for patients with hepatitis Delta.
And I'll make a closing comment. I did mention everybody should know their ABCs, but I want to say everybody should know their ABCCDs, because I want to put D into this for the reasons that Maria highlighted. And of course, the other C is coronavirus. I think with coronavirus testing, we can educate about viral hepatitis testing. Coronavirus vaccination, we can talk about vaccination specifically for hepatitis A and B. And hepatitis C is curable and hepatitis B is treatable. And now Delta will be treatable, Delta hepatitis. We have new treatments coming, more reason to treat and link to care. Thank you so much.
Thank you so much.
Thank you very much to Dr. Buti and Dr. Gish, and thank you to our listeners for joining in. As a reminder, to view the full Don't Delay with Delta program on the Clinical Care Options website, click on the link in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.